My name is Joshua Kipto. I'm a clinical pharmacist. So I want to explain a bit about what you call the aware classification of antibiotics, and this is how this is important for us as healthcare trainees or as practitioners in healthcare. So the aware classification categorizes antibiotics into three categories. We have the access group, we have the watch group, and the reserve group. The access group help us to treat a majority of conditions or infectious pathogens that are commonly encountered in our setting. And examples of antibiotics in the access group include metronidazole, we have ampicillin, amoxicillin, the commonly available first generation cephalosporins, for example, cefazolin. In the watch group, these tend to be having slightly higher resistance potential compared to the access group. And in the access and watch group, we have antibiotics, for example, glycopeptides like vancomycin, we have fluoroquinolones, we have second and third generation cephalosporins. And these antibiotics are most likely recommended as first or second line for empiric treatment for particular infectious syndromes, not any other infection. Then we have the third category, which is the reserve group, and this entirely is the last resort option, and this is only used for mild drug resistant organisms unless there is need, and also we use it for confirmed infections, okay, not randomly used. Examples, for example, linezolid and polymyxins like polymyxin B and colistin. So what is the use of the aware classification tool? So the aware classification helps us in devising feasible antimicrobial stewardship tools, and also helps us in effectively monitoring antibiotic use, because our intention is to preserve the antibiotic efficacy or effectiveness in our clinical settings, okay? Now, findings show that in Uganda currently, more than 50% of antibiotics supplied by the national or the private or the public drug stores, that is NMS or GMS, for example, are actually more than 50% of them are in the access group, ranging towards up to 70%, meaning that a few of them are really in the watch and the reserve group, okay? And also that means most of the budget goes into the access group. And like I said before, the access group tend to be having a low resistance potential, and therefore we need to make sure that much of the antibiotics we're using for prophylaxis or empiric management is mostly in the access group. Okay, I'm going to give you a scenario. For example, in the surgical ward, you have a patient who comes in with a non-severe road traffic accident with a compound fracture, and in this case, you have maybe a soiled, a clean wound whereby you just need to do some operation, try to splint, and in that case, you're choosing a drug for prophylaxis. There is a choice between vancomycin and cefazolin. Obviously, I would choose cefazolin compared to vancomycin, because vancomycin is in the watch group, and while cefazolin is in the access group. Take a scenario where we have a water contamination, and here you're combining piperacillin tazobactam with doxycycline. Okay, in that case, you also have an option of ciprofloxacin if you don't have doxycycline. But we know that tetracyclines like doxycycline are actually in the access group. In that case, I would choose doxycycline, not ciprofloxacin as an option, because the tetracycline is in the access group, while ciprofloxacin is actually in the watch group. Okay, so that is how we can apply